Introduction to ASAM levels of care for MAT providers. This is building on a lot of work we've been doing in the community of practice related to the ASAM criteria. We had some discussions around goals and recovery goals for people. We had discussions around treatment planning and making treatment objectives. So we're kind of continuing that on now. This is our disclosure for our continuing ed credit. So as a reminder, we do have continuing ed credit for LADACs, MLADACs, CRSWs, and all types of nurses. So please make sure that when you signed in, you check the kind of credit that you would like. And then at the end of session, we will be collecting the evaluations. And if you need to receive credit, make sure that we have your name. We'll check it off. So then I know you completed evaluation. I can send you your certificate. So welcome, everyone. Like I said, my name is Adelaide Murray. I work at the Community Health Institute on the project, the Center for Excellence, which some of you may be familiar with. We run a couple communities of practice out of the center, the MAT one being one of them. Melissa, my colleague here, runs a prevention and peer recovery support services community of practice. And then today you will see a lot of friendly faces that I have stolen from my treatment community of practice. So we have a community of practice of substance use disorder treatment providers, of which I robbed today, the roster, so they could come and speak with you about the levels of care that they offer here in the state. My other colleagues in the planning team include Rekha Sridhara, who couldn't join us today. We have Lindy Keller from BDAS, Rebecca Skye from the Financial Healthy Communities, Peter Mason from IDN Region 1, and Regina is there in the back. Where'd she go? Regina from BDAS is in the back. She's also on our planning team. So as a reminder, the purpose of the MAT is kind of my spiel that I do, is to support and promote the successful implementation of an integrated MAT approach in healthcare settings throughout New Hampshire. We do that in a variety of ways. Today, we are having our in-person group meetings, which are also included on this handy resource document that we made that's posted on our website, and we actually just updated it to have, this was 2019 specific, so now we've updated it for 2020. So we have our MAT Google group that you all are either added to or can be added to. If you're not a member of it and you'd like to be added, let myself or Melissa know. We'll make a note and we'll make sure that you're added to that afterwards. So to join that conversation, to look at past conversations that have happened there, you can email matnh@googlegroups.com. Then we also post, like I said, our resources on the Center for Excellence website. So this meeting is being recorded, and all of our meetings are, and they get posted to the center website. The slides get posted, the handouts get posted, and then we actually capture all the questions that are asked throughout the meeting and the answers that are provided to them, and we type those up, and those are also posted. So if there's a good question and you weren't able to catch the whole answer, you can always reference the website, and that's there. And we do that for all the meetings, so that's historically there. And then there's always technical assistance requests available through the Center for Excellence. So we have kind of a new form for that, which is nice. So it provides a little bit more information about that process, so you guys can be well informed about how that works and our relationship with the Bureau and how those get approved, and then understand, kind of the expected length of time of that process, so then we can provide you technical assistance. So I'll go through the objectives and then I'll introduce Lindy. So today, like I said, we want to talk about levels of care, and we're really excited to be able to have such a strong panel of treatment providers here in New Hampshire to represent various levels of care from also a lot of different areas of the state. So today we're hoping that by the end of the meeting, you will be able to describe the substance disorder treatment levels of care available in New Hampshire. You'll be able to identify New Hampshire providers and organizations offering various levels of care, and then identify opportunities for collaboration among MAT providers and substance use treatment organizations. So our treatment providers here today are going to talk with you about how they work with MAT providers, how they accept referrals, how they communicate with MAT providers during maybe a step down to a lower level of care or after a discharge, how they maintain communication with MAT providers, and hopefully there'll be a lot of good discussion, lots of questions asked about new relationships you can make. So I will switch it to Lindy's slide and introduce Lindy, who's going to give us, to start, an overview of all of the ASAM levels of care, and then we'll dive into our panel with some of our specific New Hampshire levels represented.
So actually, I'm going to say something before I do that, because I want to piggyback on what Addie said about the Google group and the technical assistance that's provided as part of this community of practice. And just want to say this because the community of practice keeps expanding, so that's the good thing. I remember when there were more empty seats than full seats, so this is a great thing. So I feel like there are some folks that are new to all this, so it'd be a good time to mention it. The TA thing, what I want to say, and Addie referenced this briefly, that this community of practice and the associated parts of it come out of a contract with BDAT. So we specifically fund them for certain things and not for other things. And so when TA requests come in, those have to go through the Bureau for approval, which we try to do as quickly as possible. But I did want to mention that there are some things that there have been some recent requests, and we just want to be really clear about this particular thing, that one of the tasks that they are not funded to provide is writing grant requests, so grant proposals. So I just wanted to throw that out there very clearly because first of all, it's not in their contract to do, and second of all, I'm looking at all the smiles around the face. You know that if word got out about that, they'd need to hire 16 more people just to do grant funding, which leads me somewhat to my second piece, which is that the community of practice is designed, as she rushed through really fast, but for shared learning and for problem solving. And our assumption is that the people that attend here all have some expertise in something. And as far as we know, so far, we haven't found anybody who has expertise in everything. And the whole idea is that collectively we can get a lot better at this. This is a service that we're all working at developing, some with more years than others, but it's a continually developing thing. And so I really urge you, these meetings, in-person meetings, happening every other month. The Google Group's available 24/7. So I really encourage folks to use that to raise some questions, but I also want to encourage folks that and we've had people do that, but when somebody raises a question, you don't have to have the complete answer, but if you have something that might be related to that topic that could be helpful, if you put out a piece, that might jar somebody else to say, yeah, well, but this piece works, or here's something we tried that didn't get us all the way, but it got us part way, and that collectively we're going to be able to do, to move through this a lot better and more efficiently together. Having said that, Addie also referenced the planning team, and the planning team is the group of people that puts these in-person meetings together. We take the topics from information we get that people want this information or that they need certain information around particular topics. Some of that comes off the Google group, some of that comes off of the evaluations that you turn in. We've been talking for some time about the whole reimbursement issue because we know that that is a problem that, as far as we have found, nobody has really found the full solution to yet. If you are the person who has, please let us know. But we do know that needs to be explored further, and we've been talking about it for a while. I think it's really a timely thing that kind of came up in the Google group, but it's also come up in a lot of private conversations as well. We will be working on that to try to figure out what's the best way for us to really get a handle on this, and I think we'll probably be using the Google group to say, you know, tell us what your questions are, or tell us, you know, what we need to do with this, because I don't think anybody anywhere has figured out the full answer to this. So we're all in it together. We need everybody's voice, and so we're encouraging you to participate in that, and we will be bringing more of this to one of these sessions in 2020. So
we also wanted to say that when we are able to do that and get that meeting plan, we'll let you know with plenty of time so you can maybe bring some of your billing people.
yes.
And if you have ideas on how we should have that conversation, it's all ears.
And again, you can do that through, the nice thing about the Google group is it might spur somebody else to think of something as well, but if you are reluctant to use that or for whatever reason, you can always put it on your evaluations here, or you could send in, maybe instead of a TA request, just send in an email that says, you know, here's something that I think should be a part of that conversation, or a way to get at, it's so big, we need to figure out how to get at it. So said that, okay, now I'll get to what we're here for today, and I'm gonna, look at
I'll
that.
do your
We
time.
weren't gonna start till 4:15.
Yep, you're flying.
Good. So, I was asked to do, a really quick run-through of the different levels, ASAM levels of care, and for some of you, you've heard this before, and, I'll be absolutely honest with you, I stole Paul Kiernan's PowerPoint and made some revisions to it. So some of you this may look very familiar to you as I run through it, but it's going to set the stage for the panel that's coming up here. And what I've been asked to do is say a little bit about each level of care, and for those that we have a panel member here, I'm going to be very brief because they're going to give you more information, but some of the levels of care we don't have other speakers, so I'll spend a little bit more time on those. Having said that, I know, at least for me, when I start thinking about the levels of care, I have to go back one step before that, because levels of care are based on a good, complete evaluation. They're really based on an ASAM evaluation. The ASAM evaluation encourages or requires assessment of 6 different dimensions. So as we go through this, I'm going to be referencing some of those, and maybe I need this more than you, but I had to write them down so I always know what dimension 1, 2, 3 are. So dimension 1 is acute intoxication or withdrawal issues. The second one is, dimension 2, are biomedical conditions or complications. 3, I'm slowing down because some of you are actually taking notes. I'm impressed. Thank you. 3 is emotional, behavioral, or cognitive conditions and complications. So those 3 often get put together because those are sort of like co-occurring pieces of this. And then 4, 5, and 6 are really very substance use related. So number 4 is the person's readiness to change with regard to their substance use disorder. Dimension 5 is concerns about relapse, continuing use, or continuing problems as a result of use. And then dimension 6 is the person's recovery support and living environment. So at the levels of care, pay attention to those 6 dimensions, and that oftentimes makes the difference between whether it's this level or that level. All right, I'm going to start with the one that's really not a level of care, but ASAM has added this in, and that's early intervention. And part of the reason this was added in was because this is usually a person who doesn't have a diagnosis or who is pre-diagnosis. So I'm not going to read these things to you. I think the print's big enough. The services there tell you what happens. What I want to say about this is that these are services that often in our prevention world, these are called either indicated prevention or secondary prevention. So it's for people who there's been a recognition that there's some kind of problem, but it's not yet been defined as a substance use disorder. Or maybe it doesn't meet the criteria for a substance use diagnosis, but there's still issues. And these services typically are not provided by LADACs, MLADACs. These occur in lots of other places, and some of the places you run into the level 0.5 are DWI programs, employee assistance programs, student assistance programs, other kinds of correctional settings, drug-free workplace initiatives, and then in primary care, emergency departments, and community mental health centers, where someone may be present because of some other condition. So they've not yet been diagnosed with a substance use disorder, but maybe we better be looking at this, and this is why the motivational interviewing and education is really the big part of this. The other thing that may come out of this, those of you that are familiar with SBIRT, is if the person does have meet a criteria for a diagnosis, then that's a point for referral as well, which could be listed as one of the services. going from least intensive to most intensive, the next thing is outpatient treatment. I think most of us are familiar what this is. This is what we tend to have the most of, most available of, and the services that are there. Concord Hospital will be talking more about what goes on with their outpatient services and what's involved with that. But I would say the populations that most often are involved are folks who are either in early recovery, and so they're really in that place where they just need to even be developing. Well, this is a good place where you get evaluation, so that's one. But then in early recovery where they're still trying to figure out what they need and whether they want something and treatment planning and that kind of thing, and also often need a lot of education to even understand what their disease is, or patients who are in ongoing care but need just sort of continuous disease management, or I would say continuous, that comes from ASAM language, I would say continuous recovery management. Or for people maybe who have been in recovery for some time but are under certain stress, need to kind of come back and get some help. But also for those folks who are in early stages of readiness to change. So we often, when we say it's a less intensive level of care, people tend to think it's for people who are healthier, and that's not necessarily the case. People could have a very significant substance use disorder, but are not ready to really deal with it. And in the past, I always do this because I've been doing this a long time, but in the past, okay, it's that severe, they have to go to residential. But if someone's not ready for treatment, residential is a very high level of care. Like you wouldn't put somebody in the hospital for surgery when they're saying they don't want it, right? And keep them there until they want it. And so it's that kind of thing. So it's not about the person's disease is less intensive. It's about the level of care is less intensive because it's a place where that's where the motivational interviewing and doing that counseling and helping people understand and decide move up their readiness to change. So it can be used either as a step up to more intensive or a step down from more intensive to a less intensive level. And this is also one that is often integrated with healthcare. So in those places that are health homes or F2HCs or whatever, they may have the care right there in-house. If not, there may be some kind of, as we've heard before, and we'll probably hear here, a way to coordinate those services. 2.1 is intensive outpatient. Intensive outpatient is obviously done at outpatient clinics. And Concord Hospital will be talking to us about this too, and can explain, I think, better how they make decisions around why are you an outpatient or why are you an intensive outpatient, so what the difference is in those two populations. The main difference in the actual service is that this is, you can see at the bottom there, runs anywhere from 9 to 19 hours a week, needs to be at least 3 days a week, and provides a lot more structure for folks than a regular outpatient setting would be. This does say it's 6 or more hours a week for adolescents, so it's a little different from adolescents, but this is the only one we talk about adolescents. Everything else we're doing today is really with regard to adults. 2.5 is the partial hospitalization. You can see we're moving up intensity, frequency, amount of service that the person is receiving. And with this one, again, all of them up to this point, really those dimensions 1, 2, and 3, the medical, behavioral, cognitive, and the acute intoxication, that those are issues that are not severe or are relatively well controlled. This one probably has more of a co-occurring. Again, we'll hear about this from Elliott Hospital. But this does require that the service that's being provided does have a direct access to the psychiatric, medical, and lab services that are needed in order to meet the needs of folks within those dimensions. Okay. Level 3.1 is the clinically managed low-intensity residential, is the official ASAM name for that. we've now moved into the residential services, but these are the ones that tend to be less intensive in terms of the amount of counseling treatment that folks get. And they do tend to be longer term. So sometimes these fall into transitional living kinds of situations or halfway houses. They qualify. There have to be some clinical services on site, so it can't just be a halfway house where people live there and then they go somewhere else. But they do tend to have great structure, but not nearly as much clinical services. And typically this one is used as people are moving into the community, so there's a lot more attention to people getting jobs and working out financial situations and getting themselves back into the community. Sometimes folks in these services do access either IOP or partial hospitalization at another site while they're living in this residential setting. So, oh, and I didn't mention there, I'm sorry, that Southeastern New Hampshire Services is going to be talking a little bit more about that level of care. Moving into the high-intensity residential, and it seems like a lot of words, but they're for good reason. This is clinically managed as opposed to medically managed, and then you get the low-intensity and the high-intensity. So those are some of the differences. This is a service that is really set aside for people who both have a substance use disorder and have some kind of cognitive limitations, specifically. So it's not just any co-occurrence, it's co-occurring issues that are related to cognitive limitations. So, for instance, people who may have developmental delays, people who have had brain injuries, folks, whether those are of a more chronic nature or more sudden traumatic brain injury. But for this reason, while they need that kind of residential structure and they need a lot of treatment, the treatment is done at a much slower pace and much more repetitive pace, and with a lot more accommodations to help people to get, because most of our treatment is cognitively based. So this is just kind of a different level. And we don't have anybody representing this because as far as I know, we don't have anything in New Hampshire that meets this level of care. Let me just see though, I want to make sure that I'm mentioning what I meant to mention. So really the treatment focus here is really based on helping people overcome their lack of awareness or their ambivalence, their understanding of the connection between the problems they're having and their substance use, their enhancing their readiness to change, preventing continued use or relapse, and then most importantly, trying to figure out how to promote reintegration of these folks back into the community, which when that happens needs to happen with a lot of care management and wraparound services. So the movement out of here requires a fair amount of work in and of itself. So then there are clinically managed high-intensity residential. I'm sorry, that last one was population specific. I didn't say that. 3.5 is more of what most people think of when they think of residential services. So again, you can see there, primarily, these are for folks whose addiction is so out of control that they really need a 24-hour supportive environment in order to just get started on recovery and then to be able to continue a process that they've gotten stuck and they just can't move forward. It usually requires some pretty comprehensive and multifaceted treatment that addresses everything that's going on because there's a lot. More often there's a lot of habilitative services rather than rehabilitative services, because these are folks that just don't have the coping, they don't know what they don't know. To be able to go back to that, they need to learn. And the goals really of treatment here are to promote abstinence and arrest the other kinds of addictive and antisocial behaviors that have been going on, to really change lifestyles and values, and it's a much, again, a need for a much more intensive thing with focus on stabilization, initiating a recovery process, and then for most people in this, they need to step down to a lower level of care. This is not sufficient. This is a strong starting point. Having said that, at the point that people are not at risk of immediate relapse or continuing of use in an intermittent fashion, they should be moved to a lower level of care. And this is one of the lessons from ASAM that, we've not gotten, is that if we don't send people here until they're ready to change but can't, then they should not need a long time in this level of care before they're no longer at imminent risk, at which point then the lower level of care is what's really indicated for those folks. And then, and some of these programs are also population specific, but not because of the cognitive limitations. So our speaker today that's going to talk about this is Hope on Havens Hill, which is this level of care, but for pregnant women, which is, again, that when you look at the holistic, all the interrelated needs that they would have. And then moving up one, the medically monitored. So this is not a hospital, but it is intensive treatment. And these services that are listed here are like everything that was in the last slide, plus this other stuff. And this is really for patients who have functional limitations as a result of those dimensions 1, 2, or 3. Medical, behavioral, cognitive, emotional, or still problems with withdrawal or overcoming acute intoxication that keep them from being able to focus on recovery efforts. And those limitations are severe enough that they really require an inpatient setting, but they don't require the services of an acute care hospital. Does that make sense? So it still needs a high degree of involvement of medical staff as well as any kind of substance use treatment staff. And we don't have a speaker for this either. And then finally, the highest level is the medically managed intensive inpatient services, and this is essentially provided in an acute care hospital or a psychiatric hospital. It's primarily, medical. There are very specific specifications among those dimensions 1, 2, and 3 with diagnoses that people have to have this a need for this level of care, and they really need medical or nursing care safely in a 24-hour setting. Not usually, the lead of the staff here would be a medical professional, generally a physician or advanced practice nurse. And the main focus of this is just to get people stabilized and then prepare them to move into a less intensive treatment setting where they can get more of the clinical treatment for their substance use disorder because the other things have been stabilized. So I think that covers it for me, unless people have any kind of questions. As I said, it was meant as a quick review, but if not, are you introducing the panel?
I shall be, yes.
Okay, thank you, Lindy.
Thank you. So I think before I bring the panelists up, I did just want to ask, for some of those maybe more intense levels of care or specialty levels of care that we don't have represented here today, or in some cases, right, we might not even have represented in the state. We wanted to ask if anyone had had experience either working in a level of care that maybe is a 3.7 or a level 4, or referring to a level of care. I don't remember if it was this meeting or another one, where I feel like someone asked Molly about trying to find a level 3.3 for those real cognitive specific needs, and it was really difficult. So are there any kind of learnings we can do as a group of people that have been able to find some of these higher level resources in the state or outside of the state that they've had success in referring to or working with, or maybe in a past life someplace that you worked? Anybody? Molly?
I haven't worked specifically on 3.3, and anytime, I think I recall the question, referring to that, which I had, and actually, I worked in level 4, just in hospital, but I'll tell you, that's only for medical, because we're not doing a lot yet in the hospital, which we need to be doing more, maybe, and whatnot. But, I had a guy who had a stroke, secondary to complications with substance use, and that's not surgery for endocarditis. But, it was an issue of needing both rehab, physical rehab, but also cognitive rehab. And I sent it out on my Google group, of addiction docs, and, the pages pop up, very, very specified. So I'm not sure there's a whole bunch of them across the United States either.
Yeah.
And then when I contacted that, I think that's in Minnesota, it was very, very specific too.
Yeah.
Yes, is the managed care organization gonna, pay for that, or, really gonna have that at a number. I think they're pretty limited.
Has anyone else had any experiences trying to refer to one of these more specialty or higher levels of care? Emily?
Years ago, I was contracted up at Project Mountain to come in and help them with the population that they were seeing. And they were wanting to do something for that. That was prior to them closing the hospital, but that they had identified that need, and having, a whole facility of patients that had SUD, but also had a cognitive disorder and or physical disability due to accident or whatnot, more often than not related to their SUD use. And they were really at a loss of what do we do. So they had brought me in to kind of help manage that prior to their closing of where we're going to do with these patients. Can we, open a program here? Again, so they closed, but really identifying that there was a need for it. They didn't know how to handle it, not having any SUD specific up there, and where they could go. So, yeah, difficult to find.
In the absence of easy access to these services, what are people doing if they run into patients that they feel may need this level and they don't know what to do? Emily?
I don't know if anybody went to the Nautica meeting this year, but they did bring in a doctor, I believe from Toronto, Canada, to kind of talk about, and I'm going to lay this, what she did, but I think it was like TBI, and I used, for the person that was there, chimed in, to talk about how to treat them, and basically I think her overall message, and correct me if I'm wrong, anyone that went, Sarah, was, continue to do what you do, treat them as you would as a clinician, in your level of care, because she had kind of compared it to when someone is using, they have those same cognitive impairments that somebody who has a TBI or a cognitive disorder or something would also show, and she kind of showed the room that the symptoms look the same. You need to treat them as you would as a clinician with your set of skills within your facility type of thing, and not singling them out or getting them a separate program or something like that. So I think that helps clinicians see that they can. There's a fear of like, I can't do with someone that also has a cognitive disorder, but I mean, if you really look at a lot of our patients, for those of you that work specifically with SUD, they have some sort of cognitive impairment, usually sometimes related to their studies.
So, yeah, and she's going to come back for 2 more sessions. So through the Training Institute, she'll be coming back to do more of this because, you know, we've certainly recognized that we're dealing with folks that have cognitive issues even beyond what we've seen, and basically grew out of the fact that every overdose is a brain injury. And cumulative overdoses are cumulative brain injuries, and then cognition is really severely affected in many cases. And so I think treatment providers do need to hone up more skills. But one of the things she also said was that these are really people that need individual treatment. You know, that group treatment is not really an option. And so for some of our treatment programs, that's a problem because they're group oriented. But yeah, I would agree with like everything you said, but to say that, and I will also add that her being there kind of grew out of a partnership between the SUD treatment community and the Brain Injury Association of New Hampshire, who are really spearheading this attempt to figure out what do we do with patients with the co-occurring issues. And I think so over the coming year, I'm sure there'll be a lot more opportunities for people to get some kinds of training or information, and also a better connection to the Brain Injury Association, who can help get folks who need cognitive rehabilitation as opposed to need their SUD rehabilitation accommodated to their cognitive abilities, because, you know, people can improve their cognition as well with the appropriate services that they provide.
So we'll reach out to Nahatica to ask them when that person will come back, and we'll put that information in the Q&A that we'll put on the website, and we'll probably also send it out through the Google group. Does anyone else have any other ideas or strategies, or want to share what they do when they kind of are at a loss of a level of care to send someone to? It might be very intense or very specific.
I was just wondering if anybody knows, like following rehab in Boston or some of those other TBI rehab facilities have any type of pretending?
No? Maybe we can look that up for the Q&A. All right. Thank you, everybody. So I'm going to bring up our panelists. So Lindsay kind of mentioned who everyone is, but I'll just reintroduce them again. So from Concord Hospital, which has both an outpatient and an intensive outpatient program, we have Stephanie Heath and Monica Edgar. From Elliott Hospital, which has, again, a whole slew of things, but today, talking about the PhD program, we have Carol Forlong. And then from Southeastern New Hampshire Services, which is going to be low-intensity residential, we have Sarah and Justin. And then from Hope on Haven Hill, we have Beth. So we've given them some questions that they're going to talk through for each of their level of care. I'll give each of them kind of a sign on time if they start to get wordy. But I also want to point out to you that I had each of them graciously, thank you, fill out a very brief kind of overview, similar to the slides that Lindy presented here, but specific to their program. So this is a sheet that you can take notes on as each of them are speaking, and also provides a little bit more background information about the services that they offer, the frequency of those services, the staffing that they have, and then also, very kindly of them, they each put the contact person of their program. So if you hear one of them speak today and you're like, oh boy, I have a patient that really could use that service, they give you a nice contact person to reach out to at their program. So with that, I think that's all I wanted to say. We are going to go from, look at you, sat, we're like that, least intense to most intense level of care. So we'll start with Concord Hospital with Monica and Stephanie.
In your eyes,
Oh, is this in your eyes? Do you want me to shut it down? You're okay.
Okay. It's not in your eyes,
Not
right?
in
Oh, no, I'm good.
So good afternoon, everybody. So Monica Edgar, I'm the Director of Substance Use Services at Concord Hospital. I'm also a provider at Choices at Riverbend. I'm a psych nurse practitioner with waivers, and I'm also an MLADAC.
I'm Stephanie Heath, I'm a clinician at the hospital, and I'm an MLADAC.
So we provide level 1 service, which is the individual or groups, and I'll get into more about that in a little bit, and we also provide this 2.1, which is an IOP. We also, I would argue that we do some level 0.5 early intervention. We do have a DWI program, and also we do a lot of inpatient consultations. We did about a little over 1,600 of those last year. So there are some times where that is an opportunity to do some education. In our DWI program, there are folks that do not actually need a diagnosis. So we have a group that's more teaching people about safety, preventing high-risk situations where they're drinking or other substances. So let me sort of move into, I'm going to start backwards, actually. Actually, let me give you a little bit more about sort of our program, kind of structurally. So myself, Stephanie, we have 2 other licensed alcohol and drug counselors. We're in the midst of hiring for another one, if anybody knows of anybody. Put that out there. And we have a case manager that's very helpful to help us coordinate care. And we're also supported by 2 office personnel. We're in the middle. We've been working really closely with our partnership with Riverbend to be hiring a recovery support person that would actually be staffed up in our program at the hospital. And so let me just tell you, so somebody, in terms of backing up, who's looking for services, so somebody can pick up the phone, call, we get referrals through Tara over Family Health Center, which is a federal qualified health center. She's working with folks as an IBHC over there, so she may see somebody that she sees sort of individually, realizing that they need a little bit higher level care. So our referrals come from a gamut from the doorway. They could come through there and some of the legal system too. So people they call, we do a quick telephone screening, making sure that they're appropriate age, because we are an adult outpatient program. So they're getting identified as being appropriate and eligible for our services. Let me back up too. In terms of eligibility, so Concord Hospital being a charitable care organization, anybody that's not insured or underinsured these days, they are able to come to our facility and have services free of charge, as long as they meet those federal guidelines for that. So they're brought in, they're assessed, they have an intake appointment with a LADAC, licensed alcohol drug counselor, or Stephanie, who's the MLADAC. So their assessment is actually, we do an ASAM assessment that is in the 6 domains of the ASAM criteria. So we're going through withdrawal management, we're going through medical, we're going through behavioral health, we're going through how motivated is this person, so their engagement level. We're asking about potential for ongoing problems or relapse, and then we're asking about their recovery environment. Also, part of that, we also do a lot of screening tools, not only the DAS and the audit and for SGD, but we're also doing some for psychiatric concerns. We do the PHQ-9, we also do the CLF, and we do the Columbia suicide risk, so there's some additional things that we also add to that. We're always, and if somebody's an opiate, we're always asking about Narcan. So then during that time, obviously releases and are signed and et cetera on that intake. We look at establishing, what does the patient want to do? What do they see for services that they would like to get involved in? We set up a treatment plan at that point in time. Once that's established, this patient, their case is reviewed by the team. So the whole treatment team consists of myself, Stephanie, the other LADACs, and the case manager. We, as a team, review each person that presents to our department. And then together we make a decision about what's the appropriate level of care, understanding where their level of engagement is. These treatment plans are reviewed every week in the IOP. They're also reviewed every 4th session if you're in outpatient services, so level 1. So going backwards, the IOP, so for somebody in the IOP, they have, in terms of looking at ASAM criteria, we're looking at, they have, so their withdrawal at that level is minimal risk there, and medically, they're fairly stable. They may have some hypertension that still needs to be tweaked, that's getting stabilized. They may have Hep C, and maybe they need to be clean and sober for 6 months before that's going to be treated, but there's not any severe medical that's going to keep them from engaging in that level of care. I'll speak a little bit more about that. There may be some, there's psychiatrically, they may be a little bit elevated on the PHQ-9, where that's where I'll get involved if that's elevated. Their level of engagement, it might vary a little bit, but they are willing to do that level of service to help promote their change. And dimension 5, they may have a high likelihood of relapse. And dimension 6, the recovery environment is not may not be supportive, but it will help them. The patient is able to cope in that environment. So that's sort of the IOP level of care, if you will. We then for the level service 1 is we do a lot of individual work, and we do have groups. So people can, when people go from the IOP, they can step down into level 1. So that's one way we may use level 1. They, in level 1, we have patients that come in, they have no history of treatment, and their ASAM across all the domains are fairly stable, and they're very motivated in D4. So that's where we may start them. So their withdrawal risk is minimal, dimension 1, and so we may start them at that level of care. So starting them at the lowest level, they have no treatment history, and they're motivated. So that's one way we use level 1 in terms of individual. And if somebody comes in and that's where they want to start. We also may use that level of care as for somebody that is not motivated. So that their D4 they're very high. And we're going to lose them if we put them in IOP level care. They're not ready to engage in that level of care. So we'll do that at times. I'm trying to think some of the other reasons why we use that level.
We sometimes use it as a bridge. If someone's in our IOP and they're still actively using or struggling, we may pull them out of IOP and bridge them with some individual, where we can really individualize their care, exploring, maybe looking at a higher level of care or alternatives, getting connected with MAT or other resources. So it's just a way for us to kind of step them back a little bit, for us to kind of really see where they're at and what their needs are on a more individualized level.
And another area that we use it is for the folks that may have a severely persistently mental illness. So they may not tolerate being in a group setting. So that may be the reason why you use the level 1 level service.
And I do a lot of the level 1 service at the hospital, and so I'll incorporate individual counseling, and then we also offer gender-based groups. We have a women's group and a men's group, and then we also offer an MAT group, so I may incorporate some group attendance or encourage their group participation in addition to doing that one-on-one counseling, especially with our women's group. We have a really cohesive group going on right now, so it's always a great thing when I can add somebody in there that just to get that additional support and have that connection with other people who may be struggling, or just the relatability of being amongst other people.
So in terms of answering the rest of these questions around MAT, I do provide MAT. I also provide psychiatric consultation to folks. We try to use, if we can, in terms of the psychiatric piece, because within our IDN, we try to encourage integrated care. So if that person is a member of one of our common hospital practices, we may ask them, the primary care provider, to get involved with the psychiatric piece. I can't wear all the hats there. So that's really worked out well for us, to take sort of that lift, because I do end up doing more MAT through there. We do have patients that are coming from other providers that are on MAT. They continue to manage their MAT. Sometimes they've asked me, could you take that over for now? And I say, sure. And then once the patient has stabilized, gone through our program, we can move it back to that provider. We coordinate well with the MAT folks.
So we've had a great relationship, especially with family health center providers. It's a lot when somebody's still actively using, they're struggling, so, we're able to monitor them on a closer level where we can get them in, we can touch base with them or see them every day, we can do the tox screens or the toxicologies, where, at, primary care facilities, there's so many other moving pieces and maybe less availability of staffing, so we have the ability to really, just kind of, monitor them on a different level, help stabilize, and like Monica said, referring back, in regards to that MAT piece, once we're able to kind of support that stabilization. And then a lot with inpatient consultations, if someone's in the hospital, and they are receiving MAT, we're able to, as inpatient, we'll go and consult with the patient, see where they're at, what their motivation is. If they want to explore engaging in treatment, we can set them up with intakes for our program, and then get them connected with Monica for that aftercare, so that they're leaving the hospital with a bridge prescription for their MAT until they come in to see Monica for that ongoing prescription and continued treatment. So it's been such a great resource and tool that has been available to the hospital, even when patients are inpatient, or patients are in inpatient hospital. That's all we got.
Yeah, no, questions are good.
Do you guys have a catchment limitation area? I mean, like, you can only take in a certain area, or statewide, does it matter?
No, not for the hospital, no. You just kind of get there.
Right there, getting there, yeah.
I have a question. Monica, do you provide all forms of MAT?
So at the hospital, I don't right now. That's, I'm doing buprenorphine, but Vivitrol, not yet, just because of the hospital barriers, and then Sublocade. Both those I do down at Choices. Sublocade is the subcutaneous injection, which is the Suboxone or buprenorphine.
Can you quickly talk about what is the difference between what you offer at the hospital and what you offer over at Choices? Not briefly.
Yeah. Well, I think in terms of my role?
Sure.
So my role is very similar both places, except I have more of an administrative hat at Concord Hospital. So I'm still, and I work much more closely with my team at Concord Hospital, where Shanna oversees the Choices program, and I'm an MAT, I'm a provider. I also do some of the psychiatric assessments for some of their other programs being down there, but through Choices. Choices is we're a partnership with Concord Hospital, and Choices is a program out of Riverbend. So that's the program that's level 1 and level 2.1. So we work very closely. Concord Hospital is an affiliate with Riverbend, so I report to Peter Evers, who's leaving, but that's by the point. Peter Evers is the VP of Behavioral Health Services at Concord Hospital, so I report to him at Concord Hospital.
And also the CEO of Riverbend.
Yes, sorry, I forgot that piece. Yes. CEO of Riverbend. That's how. Yeah.
Are there any other questions for?
So I think I just got confused. So you have the IOP at the hospital, and then you also have an IOP at Choices.
Choices
So
has an IOP.
two separate IOPs.
They're two separate.
Okay.
They're two separate programs serving the community.
But they're both what you would call IOP
Well,
programs.
so we have, Concord Hospital has an IOP. We Monday, Wednesdays and Thursdays, 3 hours a week, 3 hours a night, or 4 to 7, 3 days a week, so that's 9 hours.
We have different hours, we have
Okay.
afternoon and evening, and we have 145 clients, so the hospital is a smaller piece.
typically, gender-based, or do you have some co-ed groups as well? And if so, how do you determine, is it client comfortability, where they want to be, or?
Our IOP is, we have men and women in IOP, and then when they step into our aftercare, it's gender-based. So we have a men's group and we offer a women's group. And then in that aftercare, we can offer individual treatment counseling as well, which we can offer throughout the IOP as well. A lot of people will typically wait until after the aftercare, which the IOP is, the intensive portion is 5 weeks, and then they'll step down into a once-a-week gender-based group, and then from there we can incorporate some individual counseling in there as well.
Our MAT group that meets is co-ed.
Okay.
Have you ever run into someone that doesn't want to meet in a co-ed group, and what do you do with that?
So then we'll do more individual work with them. It does happen, sometimes it's the scheduling, a lot of the times it's more scheduling than anything. So then we'll set them into individual treatment.
But they can also go back to the men's or women's group.
Sure, yes, if their schedule opens, it's always an option, so we always leave that on the table. And same with someone, when someone comes in for an assessment and we're figuring out level of care, we leave everything on the table. You know, someone may come in and say, I don't want IOP, but they're open to one-on-one, but maybe eventually they want, it's always an option. So there's always room to move throughout the program. You're not stuck in one specific level of care. So again, depending on where the patient's at, what their needs are, we're able to work with them as effectively as we can throughout the course of their care at the hospital.
Yeah, we're using motivational interviewing to then move them along. That we feel really they meet criteria for 2.1 IOP.
Is this number here your referral number?
No.
Extension 406?
Don't please do nothing.
2521.
It's 603-227-70.
That's our. I know you can hit extension 2521, and then it'll put you to the front desk.
So,
Yeah.
7000?
Extension 2521.
Yeah,
Okay.
2521. There is a direct line, 230-1972. So let me text Perry on. I think I have it in my phone.
I always give it a 2521.
Yeah.
We can put it in the Q&A.
Okay, yeah. 230-1972.
Any other questions for Monica and Stephanie? All right, Carol?
So I'm at Elliott Hospital, and as was mentioned, we have a variety of services. We run the Hillsborough County North Drug Court, which involves people who have had a substance use-related felony. We have the partial hospitalization program. We have spent a significant amount of time developing a series of MAP programs in our primary care practices. And then we are continuing to expand. We started off by having an MLADAC in the emergency room to address anybody who had something that was even remotely related to substance use. And now, because that's been so successful, we're expanding it onto the inpatient floors. So that if somebody's there for endocarditis for 6 weeks, for example, this MLADAC and others will be able to go and help them begin their recovery process while they're there. And in addition to that, if there's anyone else on any of the units who, we suspect has a problem, or we might catch them with something, then we will send that person to them to begin their recovery process. But I'm here to talk about partial. So I've been running partial programs for about 30 years. I was 6 when I started. It's one of my favorite levels of care because of the intensity of it. It's the most intensive level of outpatient care. We are a co-occurring disorder partial hospitalization program, so they must have both a behavioral health, a mental health diagnosis and a substance use diagnosis. And basically they come in, 50% of our referrals are self-referrals, which is interesting to us. We get a lot of graduates who refer their friends to us, which is very rewarding, in our opinion. So they'll call for an appointment, they generally talk to somebody to find out what they're looking for and making sure that this is the right setting for them. They'll come in, they'll have an evaluation with either our LICSW or our MLADAC. We do a full assessment of both substance use and behavioral health, mental health issues. We use a variety of tools, the audit, the DAS, the SASE, the PHQ-9, the Columbia scale. We do a violence scale, and we do a Eureka, which looks at the stages of change, which is wonderful. We also spend a fair amount of time evaluating the social determinants, so that by the time this person is accepted into our program, we know if they need housing, benefits, PCP, anything that they may need, so that we begin to immediately address that. So they do the evaluation, and if they are appropriate for the setting for the treatment program, right after that evaluation, they'll meet with a case manager who will review the handbook, have all the releases signed, and begin to develop that treatment plan that same day, so that we're moving quickly on these things. And we have a great system. If they don't have a PCP, we use a provider finder so that we can begin to address an assignment to a PCP, either within the Elliott system or in the community. We have a great collaboration in the Manchester community, and so people are very welcoming and eager to work with us. Then they start the program. The next day, they will go into the group program, and that day they will also meet with our nurse practitioner. She's a psychiatric nurse practitioner. We also have a psychiatrist who oversees the program. They are both waivered providers, and so if they need MAT, we'll begin that process also. And we provide Suboxone, Vivitrol, Sublocade. And the program is 20 hours a week of group, but it's a minimum of 20 hours a week. And so they will also get case management on at least a weekly basis. They'll see a peer support recovery person. There is a nurse that will assess some of their medical issues or help them with those medical issues, even if it's just connecting again to a PCP or coordinating that care or explaining what is needed to a PCP. The groups are mixed gender. We haven't had people request gender specific, but if they do, then we'll accommodate that, and we'll also make sure that they get individual work as an adjunct. So we do medication management, not only for their mental health issues, but as I said, for the MAT treatment. We provide family counseling. We will have a family group session. We are trying to, right now we've just been bringing in families individually, but we're going to start having a family education morning so that families as a whole can come in and listen to the other members of the group and get support that way, and also learn more about the family illness of addiction. We have an aftercare group that is open to people who have graduated in the past, so that if they're having a difficulty, they can come in and kind of get refreshed on what they need and get more support, but also for those people who are being very successful, to have the chance to come in and share that success. And that helps them celebrate their recovery, but it also gives more hope to the people who are currently in the program. We do lots of patient education. The nurses, everybody in our program does a group, so it's not just the LICSW and LCMHC. Case manager is a train the trainer in illness management and recovery, so he will come down and do groups on that, depending on their illness. Sometimes illness specific, just sometimes generalized mental health issues. In terms of MAT, as I said, we've been developing more and more family practices who are offering MAT services. I was part of the City of Manchester had a project in which they had some of us become academic detailers. And so we learned how to ask questions of medical providers, and we went to those providers and first of all found out why they're not doing medication-assisted treatment, and answered all of their concerns and gave them lots of resources so they felt more comfortable. So a year ago, we had 3 MAT providers in our medical practices. And today we have 48.
Great.
So we're really continuing to expand. Shannon is one of our nurse care coordinators who works in our MAT practices. In some practices, we have both a nurse care coordinator and LADA. Shannon right now is working by herself and developing some of these additional practices. So that, and that's one of their selling points when we go and talk to providers, that really she is the assistant and making sure that all of that care coordination is done. When I was going out and speaking to some of the providers about why they weren't MAT providers, what I heard frequently was, well, it doesn't work. And why doesn't it work? Well, because I give them the medication and it doesn't work. Meaning they were never connected with any services, any follow-up. That's Shannon's in our nurse care coordinator's job, to make sure they're connected with those clients, to make sure they're getting follow-up, to make sure they're really connected, and if they're not, why aren't they being connected? So that's a help to the providers, and should make their job easier. We also refer to other agencies in the community that are MAT providers. We don't just stick with Elliott providers. There aren't many in the Manchester community, so there are several community groups that are working to expand that. Next spring, Elliott is hoping to have a standalone MAT clinic so that people from the community, if they're looking for MAT services, can come in, start the MAT, be stabilized, and then we'll refer them back to their PCP or another agency so that they can continue. So it'll be a bridge program more than anything else. And we certainly accept lots of referrals from MAT programs. You know, it's interesting to me that partial hospitalization is not a level of service that's very well known. I've had people ask me what is partial hospitalization, and it's something new, and I have to say, well, the first one that I did was 30 years ago, so it's not that new. But it's not a very well-known service. There aren't many. I think there's maybe 3 in Manchester. But it can be a step up from IOP, can also be a step down from inpatient or residential care, if people need that support. The thing that I like about both PHP and IOP level of care is people go home. If they have a stable home or a supportive home or someone that can support them at night, they can go home at the end of the day. They can try the skills that they've learned, and then they come back, and if they've done well, what went well? And they can share that with the group to add more support and hope to the others in the group. And if they didn't do well, if they had difficulties, well, then we're going to know right away what were the difficulties and what could we do differently so that they're not out there struggling for days on end. The next day they can get those supports. We provide aftercare. Not only can they come to an aftercare group, but the first month after they've completed the program, we are in contact with them to find out how they're doing, and then every 3 months after that. So we hear some great stories about how well people are doing, but we've also been able to catch people who are saying, boy, I'm really struggling. You know, the last couple of weeks have been hard. And after that conversation, sometimes we're able to get them to come back and try PHP again so that they can begin those skills again and hopefully not spend too much time before they are back in recovery. That's all I have. Yeah.
What's your average length of stay or the range of length of stay?
The average length of stay is usually about 3.5 weeks. It's full to the completion. The program itself is 4 weeks, 20 hours a day in group, usually another couple of hours a week with case management, the MAT, nursing, individual. Yeah, it's a pretty intensive program.
Insurance.
We accept them all.
Medicaid included.
Yep, Medicaid and Medicare. And if people come with no insurance, we have this great system where we can make a phone call to the hospital, and there's somebody that will work with them on insurance, and usually within a couple of days we have an active insurance.
Well, just to jump back, IOP, is your program a certain particular length?
Ours is 4 to 6 weeks, average about 26 sessions, or 15 sessions. We just started, probably in the last couple months, of stepping people down, so they transition better into level 1, so they may do like 4 weeks of intensive, and then the last 2 weeks, maybe twice a week. And we also have a family part, which I forgot, Donna Marsden, I'm sorry. Donna comes and speaks once a month to our group. She manages or runs the families sharing without shame, and she does come every once a month to our program to talk to our participants and their families.
I would also say, you know, I said the treatment planning starts on the first day, and looking at the social determinants of health starts on the first day, so that by the end of the program, they have follow-up appointments with primary care, with a therapist or a treatment program, and MAT appointments. So all of their referrals and connections are made before they leave. We think that's critical.
Regina, did you have a question in the back?
I was just wondering, do you have certain days where you do, like, intake or induction, or if somebody calls, how long it takes them to get in, sort of like how the flow works with Valley?
So when people call for an evaluation, we're usually able to get them in within 72 hours for an evaluation. And we do it 5 days a week, so it's up to their schedule and how we can best serve them. Yes, ma'am.
What's your maximum number of clients within?
12.
12. Your waiting list?
No.
What's your referral number?
So I have this incredible case manager called Bob Tamposi. His number is there,
Okay.
and you can call him and he'll give you everything you need, or transfer you to someone else who can.
Are you at capacity right now, Carol?
We always try to have 1 or 2 openings so that if we get a call and someone needs to get in, we can get them in. So it's a rolling program.
Any other questions for Carol? Emily?
How are you billing Medicare? Is that under the hospital thing, for the sub-services?
Right. We'll bill them for the professional services, and then we write on for that.
Thank you, Carol. All right, next we have Southeastern New Hampshire with Sarah and Justin.
Hi, I'm Sarah. I'm the Assistant Clinical Director at Southeastern New Hampshire Services, which is in Dover, New Hampshire. This is Justin Younger. He's one of the case managers in the program. We're here to talk about Turning Point, which is our low-intensity residential program, but we also have outpatient services. We have a women's-only IOP. We also do the IOP and outpatient counseling for the Stratford County Drug Court, and then we have DWI programming as well. I think that's it. So Turning Point, the 3.1 program, there's not a lot of 3.1 programs in the state. There's us, there's Headrest, there's Keystone. I think that might be it. We are the largest 3.1 program in the state. We have 28 beds. That's 16 men and 12 women. The key component of a 3.1 residential program is that it provides safe, secure, sober housing for people. It is not as high intensity as what your so-called traditional 28K program would be. It is much more of a transition back into the community. It might be for people who might qualify for an IOP, for example, except in Dimension 6, their living environment is dangerous for their recovery. So maybe they're in an abusive environment, maybe they're in an environment where people are still actively using substances around them, maybe they're homeless and are living on the street and have no access to housing, have no employment, can't find housing. We get probably the majority of our referrals from high-intensity programs. That's because if somebody isn't in a high-intensity program, they tend to be either in need of a high-intensity program or in need of detox because they're in crisis. That's why we also don't get a lot of referrals from the doorway, because people going to the doorway tend to be in crisis and are in need of those higher services. We do sometimes get referrals from like Portsmouth Behavioral Health Unit. Maybe someone was sober for a while, relapsed, and then is getting back on their feet, but has had some, excuse me, I'm kind of losing my voice, experience with sobriety, have some skills to be able to remain sober outside of a 24-hour environment, but still needs that support, especially that housing support. I think we've gotten exactly one referral from a doorway for somebody who is actually appropriate for 3.1 level of care. To be appropriate for a 3.1 level of care, somebody, like I said, has to have a living environment that is dangerous for their recovery. The ASAM textbook specifically uses the word dangerous. So you can't just not like your living environment. It has to literally be dangerous for your recovery. Or for that, sometimes that person might actually have a stable, sober living environment, but just has not been able to stay sober in it no matter what, even with an IOP, with MAT, with outpatient counseling, just has not been able to over and over and over again. And so for that specific individual, then maybe it would be appropriate care. In terms of dimension 5, they have to be at moderate relapse risk. Somebody can't be, in so at high relapse risk that they're going to be, that because they're detoxing or they're about to use this minute. They have to have some ability to stay sober outside of a 24-hour environment for at least a small amount of time. Dimension 4, for a 3.1 program, Dimension 4 is interesting because it can be either people who are motivated for treatment or people who really are unmotivated. But ASAM says you should really house those people separately, which, unless you have a really large facility or multiple facilities, really impossible. Dimension 3, people have to be stable. So they can't be in active psychosis, they can't be suicidal. The definition of stable is a little mushy, but they can't be in need of a higher level of care in that dimension. Dimension 2, again, in terms of biomedical complications, they have to be stable, and Dimension 1, they have to be able to be treated on at most an outpatient basis for withdrawal. So for our program, what we do is somebody calls up and they do a phone screen, and then if they're coming from another facility, we get a whole bunch of paperwork from the other facility. We have them fill out a form that says, yes, they do meet we do believe they're going to meet criteria for a 3.1 program upon discharge. Here are the reasons why. And then they come in, we do a full ASAM assessment. We use the continuum assessment tool that is ASAM specific assessment tool. I do all of those, and then they come in, and we have, our program's a little different in terms of 3.1. 3.1, the hours per week required is minimum is 5. Ours, we provide services of anywhere between 6 and 31 hours per week. That's groups, that's individual counseling, that's case management services. Unlike these other programs, we don't offer medical services. That's because this level of care is not required. We do have a partnership with Families First, where anyone who's a patient of Families First can see them on Fridays. They come to our facility. And then we also, our case managers hook people up with primary care doctors in the area. But we don't specifically have medical services on site. We do work with MAT providers off site as well, though. I've lost my train of thought. So somebody comes in, what we do is we have them in an orientation phase at first, and that's to continue with assessments, continue with stabilization. Also, insurance companies, we found, don't often pay for 2.5 or 2.1 in conjunction with 3.1, even though ASAM says that you can do that. So we have the option on site providing people with more hourly services per week if they need that kind of support and structure. But once people arrive, after they go through an orientation, They then go out in the community, they go to outside meetings, they make sober reports, they find employment, or if they're on disability, they do volunteer work. We require a certain amount of volunteer work or employment within a certain time period. And then they come back and they continue to go to educational groups, support groups, counseling, and stuff like that. They work with a case manager and their individual counselor. And Justin can speak to more to what we provide in terms of any support.
Sure. Hi, my name's Justin. I'm a CRSW case manager for Turning Point on the residential side of the building, like Sarah was saying. With the MAT particular topic, I'll just say that we have come a long way with MAT and reducing the stigma around it or any stigma around it, and it's becoming more prevalent in the area and accessible, and I just want to say kudos to that, because there's a lot more facilities popping up that have been helping people that need this, that truly need this, and way back when I started working originally I worked for the IDN, housed out of Southeast New Hampshire Services as a case manager, and I go to different hospitals, and I remember that it was somebody would request to be on MAT, and it was like jumping through hoops a couple of years ago, to really get somebody established with Clear Choice or, with any kind of care really. There would be like a waiting list, or the doctors will be full because they can only accept 90 patients, the ones with their X waivers. Now it's just, it's become a heck of a lot easier a couple of years later to be able to navigate somebody into MAT treatment for their request. So with that being said, sometimes you get people that are already established, like Sarah was saying, with an MAT provider. Sometimes we don't, so part of my job as a case manager is to get them established if they want to get established, like if they want to get on Vivitrol, if they want to get on Suboxone, or Subutex, or the Sublocade shot, or I think they even have an implant now that lasts up to 6 months. I don't know if that's a thing in the state yet, but I know that's something that has been being worked on, or tested anyways. So as a part of my job, I work individually with each client, and like I said, I'll help them make phone calls if they need to. A lot of the times, it's mainly in that orientation phase and that first time that I'm meeting with a client, that first or second time, because the orientation phase can last anywhere from 7 to, somewhere around 20 days. It depends on the client and where they're at and stuff. If they're, stuck in the house for 20 days, they have no phone and stuff like that because they just got out of a 3.5 or they're homeless or they just came from jail, we'll help assist, I'll help assist, or me and Crystal will help assist in some of the RAs with making phone calls with the client, because they don't have a phone to utilize. So we'll be able to use our landline phone to make those calls and make those connections, establish care with Families First or Davis Goodwin in our area, or Clear Choice, and I'm trying to think. So,
But our facilities come a long way in terms of MAT as well. Way back when I used to work there, the first time I worked at Southeastern back in 2010, 2012, we didn't take anybody on MAT, and nobody was on MAT. I mean, it was rare we'd run across anybody who would want to be on it. It was still very much stigmatized, and now I'd say the majority of our people with an opioid use disorder are on MAT, at least Vivitrol or Suboxone. We've not had anyone on methadone before. We've accepted people on methadone, and they haven't shown up, or for various reasons, and they've just never actually made it to our facility. And a lot of that, I think, is a transportation issue. We are in the middle of nowhere, kind of, so getting to the methadone clinic each day is a challenge with CTF. But yeah, this has really come a really long way in terms of MAT.
And with that being said, speaking of transportation, the biggest barrier between sometimes with setting the clients up with an MAT provider, whether it be Clear Choice or Roads or wherever, right? We get them established, and then we set up that ride, that CTS ride, and they don't show up is our biggest barrier, and I can't say enough, that CTS not showing up, it's really hindered the process of getting them onto the MAT or getting their Vivitrol shot or getting them bridged, right? They're in jeopardy of going into detox because maybe they've been on Suboxone or methadone or whatever it is, the MAT for several weeks now, and then here we are, stuck without a ride to get them to the provider. That's one of the barriers that I face on a day-to-day, on a day-to-day challenge with CTS anyways, and the transportation. So sometimes we're able to provide bus tickets to them to get them to like Goodwin, but the bus doesn't run always en route to all these different places that provide MAT services. So it can be a little bit of a challenge. And then last thing we want to do is have someone going into detox or whatnot.
And that goes back to the functional limitations that people have to be in level 3.1 is that they don't have the support system, they don't have the employment or the car that they can get them to these appointments. Most of our clients are on Medicaid. Level 3.1 is interesting. Medicaid covers it, but most private insurance companies do not. There's some weird branch of ASAM that does that I've never run across. I'm not even sure if that's real or not. But the good thing is that BDAS does cover it. And Medicare, of course, doesn't cover it because Medicare doesn't cover anything. But again, that can go to BDAS. But so most of our clients are on Medicaid, which also goes back to that functional support limitations that people have is people who on Medicaid tend to not have the job to house the family support. So even if actual insurance, private insurance companies cover that level of care, I think we probably end up getting mostly Medicaid people as well.
I just want to clarify that, right, CTS is the transportation service provided by Medicaid, right?
Sir, New Hampshire,
They use,
I don't think AmeriHealth provides it. Or I've had challenges. Maybe.
they contract with local cab companies and stuff.
AmeriHealth does do it.
They do.
They do it? Okay. I only had one person, and somebody told me, but yeah, okay.
Any questions for Sarah and Justin?
Are all these services that we're talking about today open for people who have alcoholism and primary substance?
Definitely.
Yep, absolutely.
How many beds do you have?
28.
And is there a waiting list? Is it harder?
It depends on the day.
Depends on the day.
Right now, 26 beds are full, the other 2 are being filled on Monday and Tuesday of this week, next week. So, but that could change over the weekend with people, having that access out in the community, but still not having the support or the daily structure. Things could fall apart, and we could lose half the house and one fell swoop.
Gotcha.
It's all
I
over the
also
place.
just want to mention, there was a pilot project down out in Wisconsin, out of the University of Wisconsin, for some of the programs that were out in the country, basically. And what they did was they actually partnered with some local recovery groups, and they were able to do transportation every single day as a service piece of their recovery. I've never heard of it before, and I don't know what the legality of that is in terms of insurance, all of that stuff, but they did, they're pretty successful in doing that because of their rural area.
Good to know, thank you.
Peter?
What's your average length of stay?
We do up to 90 days. It could be anything less than that. I think the least I can think of for somebody who successfully graduated was about a month.
And it's interesting, talking to folks from Headrest, they struggle
with people who come from a more intensive level of care who show up on a cocktail of all kinds of medications. And it makes it extremely difficult to even know who they are. And so cooperating with any kind of therapy at that point is difficult over the first whatever period of time. And they talked about how do they interface with medical people and get these folks off of all these medications, because a lot of the higher levels of care do symptom management. So if somebody can't sleep, they put them on a sleeper. They say they're depressed, they put them on an antidepressant. They say they're anxious, they put them on an anti-anxiety, anxiolytic. And then they put them, I mean, people come in literally on 5 or 6 different medications, and you don't know what their baseline is, and it's very hard for them to cooperate.
We've absolutely had that problem. We've had people come in and they're dozing off in groups because they're on toxin, they've had a sleep problem, they're on an anti-anxiety medication. So all these things are being targeted, but they're all having the same presentation. They're all, they're all causing them to fall asleep on one level or another. So that's been a pretty big challenge for us, especially without that medication component in-house.
Way back, we didn't accept anybody, even if it was, gabapentin per se, So we've definitely come along, we've definitely come a long way, in terms of that, because we accept anybody on it, and just,
Any medication
now, I'm pretty sure it's illegal not to, question?
Just curious, I know a lot of hospitals struggle with, they have patients on 6-week antibiotics because of sick line. Would you accept that kind of person?
It would depend on the person. Would they need a nurse to change the line?
Yes, but I hear you're doing some transportation, but I also wonder about having a visiting nurse come and helping to manage.
A visiting nurse would come, that would be, medical and psychiatric components can't get in the way of the day-to-day treatment. People have to be functional enough to be able to participate in treatment actively, to go out and do volunteer work, to get a job. So as long as it didn't interfere with that, we'd love a visiting nurse to come, or if they could do it themselves, or.
Remember we had somebody that, we had an individual that had something with his leg or something, and he had a nurse come in, during his 90-day stay, and the nurse had, it had to be a nurse, that came in and rewrapped or remandaged, daily, his leg. So we have had that happen before in the past. And we just don't, we're not a medical facility, so, we don't provide that kind of care, but we, welcome it anyways.
And there's enough supervision
Yep.
as far as somebody misusing it.
Oh, yeah, so I forgot about that part. We have med rooms where all medications are locked up. Our staff is non-medical, but they do observe everybody taking their medications. And then, we have staff on 24/7, because that's one of the components of this level of care, if there's somebody has to be there 24/7. So we have PRSWs, and then we have MLADACs, LICFWs. But like I said, we don't have the actual medical component.
Emily?
Well, I just kind of piggyback off that, the hardest part is because most of these levels of care, what therapists for level of care and what we do out of interim health are clinically managed, they're not medically managed. So, some programs do have access to medical, but they're not required, so it is very hard to have someone who may have some medical issues going on that are above and beyond what, medical doctors can handle, RNs can handle, things like that, because it is a clinically managed, not medically managed program.
Beth?
Hi, everyone. I'm Beth O'Dell. I'm the clinical director for Hope on Haven Hill. We are a level 3.5 high-intensity residential treatment program for pregnant and parenting women 18 and older. We also offer 2.1, 1, and sober living. I'm not going to talk about those today. So our 3.5 residential house is an 8-bed facility. The moms there can be pregnant or postpartum. Up to 1 year is the typical age range of the child. They don't necessarily have to have their child with them to participate in our programming, but be working towards reunification. A lot of our referrals come from DCYF and hospitals following birth. So, we are not a medically managed program. We don't have medical staff on site. Our executive director, Carrie Norton, is a nurse, but that is not her primary role there at the house. So for people coming into our program, they do have to be medically cleared by a doctor and be stable to not have any functional deficits that are going to prevent them from participating in daily programming. Our programming is very structured and very strict throughout the day. They do 3 hours of clinical group work every morning. They have a lunch break, followed by another 2 hours of life skills group, followed by daily chores, family-style dinner, followed by more groups in the evening up until bedtime. And that's every single day. We do partner with a lot of community agencies that come into the facility to provide other supportive services for the moms and babies. We work very closely with Early Head Start and Early Support Services to make sure all of the babies stay on track and that moms are able to attach and attune to their new babies beginning in pregnancy. So we have a couple of case managers as well. We have a LADAC at the house. We offer pretty much everything that everybody at the table has already mentioned in-house. Because we're not a medical facility, and they have to be medically stable. Most of our women are on an MAT program. Most of them are or have been at some point an opioid user, and come to us already on MAT. For the moms who are actively using upon screening and saying that they want to get into treatment, we encourage them to go through a detox program or talk to an MAT provider, because if they are pregnant, it can be harmful to the baby to just stop. So we do a lot of education just on the phone for pregnant moms. I will say it's a little bit tricky if we take women from all over the state. So when they're on Suboxone, it's a little bit easier to bridge because like Turning Point, we observe medications, we store medications in a secure room for observation. So when they're on Suboxone or Subutex, it's a little bit easier because they can bring prescriptions in and continue taking it with a prescription up until we can get them into agencies like Goodwin, Rhodes, Clear Choice, and other providers that prescribe Subutex or Suboxone. ACRC is our local clinic for methadone, so having women transfer services to the local clinic or set up rides to get back and forth. Again, like Turning Point, CTS is probably our biggest barrier because the moms on methadone maintenance, they go every day to the clinic in the morning. They can go as early as they want to, as long as they're back in time for 8 a.m. for our services to start. So they are in a concurrent treatment program through that clinic as well. We do our best to communicate with those programs, especially if we start to observe a lot of somnolence. It's easy to know when there's a dose change with Subutex or Suboxone because we'll get a prescription from the provider to let us know, and we keep that with their medications. Unless the women are really transparent with us, and sometimes they don't want to be, we don't necessarily know if there is a change to their methadone dose. So if we notice any symptoms, we get on the phone with the clinic with the women just to touch base with their clinician there to let them know what we're observing in treatment, because sometimes the women aren't reporting it themselves or they're reporting different symptoms. So it's good for us to keep in touch with them. We also have a wonderful woman named Martha, I wish I could remember her last name. She's a LADAC who does tobacco cessation groups at our program. She comes in on average about once a month, and she can also work with the women individually to meet their tobacco cessation needs. We do support women on nicotine replacement therapies as well, because we only offer smoke breaks 5 times a day. Sometimes less, depending on the structure of the day. So we make that a regular conversation with the moms to make sure that they're getting those needs met as well. And then I think that's generally everything encompassed in that program. We do offer aftercare planning, so again, with the MAT, if they're not staying in our local area, making sure we're working with them to transfer those services back to the area where they choose to reside. Once they leave us, getting into a lower level of care, we work really hard to have the women step down from our program into 2.1. That's why our 2.1 program was developed. We opened the residential house 3 years ago and quickly noticed the need for step-down treatment. So that's where our IOP and outpatient services stemmed from. And then we realized that there was a need for housing, so that's where Abby's Place, our sober living facility for moms, came from. So in all of our programs, except women on MAT, to include our sober living house. I think that's everything that I
Questions
have.
for Beth?
Yes.
This is actually a question for anybody up there. I'm curious if any of your programs are utilizing AccuDetox in the NADA protocol.
Just easy what?
AccuDetox, your acupuncture?
Acupuncture?
Yes.
Not detox, we are looking at possibly having a doctor that is certified with acupuncture coming in, recovery, or level 1 groups.
Anyone else have that? Emily?
We have opened our facility through Laura Cooley, for the hours needed for certification. So, because we don't have someone on site fully trained yet, coming. So we are at 3.5 right now. We also have outpatient, but, it helps because a lot of our, women that come through are detox trained when they get there. And then it helps for group therapy. I mean, a lot of them have trauma, other issues going on, and it can be hard. I've been working with Rob and Laura Cooley on becoming a training site for the people who want to work with certification and opening up our facility for them for that.
And a number of the recovery centers offer it.
So Emily is at Antrim House, for those that don't know, she said she's at 3.5. And Antrim House is in the town.
The town of Antrim.
Thank you.
For some of the sobriety centers in New Hampshire, Antrim House was the first to come about. We have an outpatient program that does MAT and therapy, and we also have a residential unit that is women only. Our outpatient is co-ed. We own the property next door to our Antrim facility. So 2020 is going to be a year of adding more levels of care for us. We're also in the process of acquiring a third property in the Manchester area. So we'll have more levels of care, hopefully.
Stay tuned. Other questions for Beth? I wanted to ask Beth, since it came up for most others, how long women tend to stay in your residential program?
We, on average, is designed as a 6-month program. We have 3 different phases to that program. So the first phase is, I hate to give numbers because it's so specific to like the person, but on average, we'll go with 60 days to 2 months, where they're really connected to the house. It's very traditional inpatient. Phase 2 allows for a little bit more independence, so we kind of like ease them into it so they're ready to leave the program when they graduate. So phase 2 offers recovery passes and personal passes. Personal passes can only be taken with people who attend our family friend orientation. And then phase 3 expands on that independence that they've developed in phase 2 and the skills that they've developed, and also allows for additional personal passes, recovery passes, and opportunities to start volunteering in the community to connect.
So I just wanted to say that kind of as Lindy mentioned in her talk about kind of the difference between more, let's say, traditional 3.5 and then the population-specific 3.5 that Beth has, where she kind of starts to already step people down while still maintaining a level 3.5, which is a little more specific due to the population, right?
Yeah. None of their recovery and personal passes and volunteer time can take away from the amount of clinical work that they do. So they have to participate in all of the morning clinical groups. They have to still meet with a case manager for a minimum of an hour a week. They still have to meet with their LADAC for a minimum of an hour a week. So all of those things still have to be met in order for them to utilize that free time that they get to integrate into the community.
And what do you do about transportation? Women are going to prenatal visits.
Yeah, we utilize CTS, which is, as anybody here knows, can be a nightmare. We will offer some support ourselves in an emergency situation. I think we're trying to get ourselves to be CTS certified so that we can just transport women and make sure that they get where they need to go. At some point,
Hospital in labor?
What?
How do they get to the hospital in labor?
We usually know about when women are going to be delivering. Some have scheduled C-sections, some have scheduled inductions, so it's well planned. But there have been middle of the night, the on-call person being like, hey, water just broke. So we get out of bed and we go take women to the hospital. But what was the original question? Because I lost my train of thought on that one.
Okay.
Yeah. We're blessed to be on a bus route as well. So there is a bus stop right in front of the house that we'll provide bus passes for women if they're trying to get to meetings. We encourage women. We bring a lot of people for the women to network in-house. So we'll run meetings in the house. We'll have guest speakers from the sober community come and speak at the house, and we encourage all of the women to really make connections and ask for numbers so that those sober supports can also provide transportations to meetings on recovery passes and so on. Some people whose families don't mind traveling an hour plus to help support taking them to appointments can also do that.
Any last questions for any of our panelists? Thank you all very much. So I do have one other little thing, which is a little hand-raising activity, if you can bear with me. This is our 2020 COP meeting schedule that I sent out through the Google group, and it's also been posted on the Community of Practice page. There are a few of these dates, I don't know offhand which exact ones, but a few of them where our room here at our regularly scheduled time does have a conflict. So we have three choices that I would like you to raise your hand and vote on. One is to shift our meetings a half an hour later, so that they go from 3 to 5. I'll just say that given the number of bodies I've seen had to leave already early, I'm just filing that away. They're not here to vote because they had to already leave early.
They already voted.
We can have our meetings at the same time at another place in the Concord area, or we can have our meetings at the same time and maybe do a little bit of a rotate in other areas of the state on these days. It's not all of them, I think it's maybe 2 or 3. But on those days, perhaps we could hold a meeting over on the Seacoast area to give a little relief to our Seacoast providers, or maybe over on the western part of the state. So those are your three choices. So the first one being, if you want to have our meetings go later from 3 p.m. to 5 p.m., please raise your hand. That's a Okay, okay, we got a few. Then we have, at the same time, but at a different location in the Concord area, so a little central. Okay, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, you got that? Yeah. And then at the same time, in a different area, we might rotate parts of the state.
Can we vote twice?
Sure. Your second choice. All right, we've got 2, 3.
Rank voting.
Rank voting. So I think what we're going to do is, for those days, we'll find a location in the Concord area where we can keep our meetings at the same time, it sounds like. And we'll be sure to give a lot of note the different location when those meetings come up throughout the year. But I think for February, we'll be okay. So we'll see you in February. Don't forget to turn in your evaluations. Melissa will head to the back. Please be patient with her. She's kind of pregnant and might be a little slow to get back there, but check off your names, and thank you all for coming.
Thank you.
Thank you. Thank you, everyone, for joining on the phone. I'm going to shut it off now. Have a good day.